must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show. Hello, everybody, and welcome to another episode of the Healthcare Education Transformation Podcast. My name is Brandon Pollen, and of course, as always, I am joined by my fellow co-hosts, F. Scott Fiel and Stephanie Wyrock. And today I have the esteemed pleasure of welcoming Dr. Julie Whitman, who is the current director of the Evidence in Motion Orthopedic Manual Physical Therapy Fellowship Program and the Evidence in Motion Post-Professional DPT and Musculoskeletal Management Programs. Now, I must add this disclaimer that I will be starting the EIM Orthopedic Manual Therapy Fellowship this fall. But the goal of this episode is really to talk about and get the perspective about an orthopedic manual physical therapy fellowship program, and also to kind of gather thoughts from someone who's perhaps in a director role and about some issues that are currently facing fellowship. So Julie, thanks so much for taking the time to come on the show today to speak with our listeners, and thank you for your service and your dedication to this profession. Now, for our audience who hasn't heard of you, do you think you could give our listeners some background into who you are and how you became the EIM Fellowship Program Director?
Sure. Hey, thanks, first of all, for having me on your show. From a professional side, I guess I'll go back to really where I went to PT school. I was a military brat, and I ended up going to the Air Force Academy and then straight into the Army Baylor DPT. Well, it wasn't a DPT program then, the physical therapy program, and that was graduated like almost 25 years ago. Can't believe time's flying. I was in the Air Force. I was an Air Force active duty officer for 12 years as a PT and then a reservist for another 2. Got out, went to Regis University and taught there for 4 more years. And that's really where I got exposure to teaching in the kind of brick and mortar DPT program, and then a transition or post-professional DPT and then a manual therapy fellowship. And then really for personal reasons, our family moved to California like a decade ago. And that's when I really moved over and started working for Evidence in Motion, which has been great because the founders of the organization are all people that I had known for 20 plus years in the military. So they're kind of family and colleagues. So then started that fellowship in 2008, and then our DPT program a little bit after that. And then since that time, I've kind of worked in primarily those roles, some consultation roles for others. And then I guess you asked about just me as a person. So mom and a wife. I've got 2 kids. I'm a homeschool teacher. I have a new love of karate. So I've been doing that for about 4 years. So it's good to go back in the learning process again.
What belt are you on right now, Julie?
Just went through a brown belt test. So that was a big deal we've been working on for quite a while. So I did that along with my brother-in-law and nephew. So that was pretty cool. Yeah.
Awesome. Awesome, Julie. And, for someone who perhaps has thought about one day becoming a fellowship director, is there maybe a type of person that you would recommend for the role as fellowship director? Or maybe if this makes it easier, is there a type of person that you would not recommend for the role as a fellowship director? Like, are there just some qualities that are really good fit for that position?
That's a good question. I honestly feel like there are like many types or styles of leaders that could serve in this position. But a big sort of essential key is that the director is really motivated to invest in the students and the mentors and faculty to really build them up. So I guess in this sense, it's kind of like in patient care, that dedication to the others and caring about them to nurture and grow them are really important traits. I think that good communication skills and especially conflict resolution skills are important, which you might not initially think of. But of course, when students are being taxed and they're juggling, their education and training and work and family, oftentimes there are stresses and struggles that come up. And the balance, I think, is really that balance of trying to hold your standards of performance for your program with people's real life issues. So trying to really not degrade the person and build them up, but still hold the standard, I think is important. And I guess the other one is organizational skills is obviously key with all the paperwork and bureaucracy that's sort of involved with the credentialing processes.
I really love what you said, Julie, about how, there's different styles of leadership and that, it's just not one type of style that's going to make somebody an amazing program director. Are there certain prerequisites as far as certifications or degrees that a fellowship director must have, basically based on AOMT or any other specific fellowship rules before they can even be considered for this position?
It's an interesting question, and it's really not totally clear in the standards. You'd think it may be more clear. One person on the faculty team has to be, like for the manual therapy fellowship, one person has to be a fellow of the American Academy of Orthopedic Manual Physical Therapists, but the director actually doesn't have to be. So if you think about like Carol Jo Titchener was the director for a long time for the Kaiser Hayward residency that then morphed into the fellowship. But she wasn't a fellow, but she had an excellent team around her that were more in the nuances and the weeds of the subspecialty. But she was a great leader. So as part of the whole credentialing process, directors do submit CVs for review, but I haven't actually heard of anyone being denied accreditation because the director wasn't qualified, but that may be because qualified people tend to push to be directors and to run programs. So I'm not sure.
I think that's really interesting, Julie. We're kind of really learning that there really aren't so specific, clear standards in regards to being a fellowship director, and even the fact that the director doesn't need to even be fellowship trained. So, with that being said, kind of knowing that the new changes and maybe the proposed standards for acceptance into a fellowship program, what are your thoughts on overall this phenomenon of maybe not necessarily requiring a certain level of staff and even the director of being fellowship trained? Like, do you think that the fellowship, someone going through the fellowship is a good thing to have in a program director, or do you think it's not necessarily needed?
Yeah, I think it's helpful, and probably some research experience would also be helpful, simply because of what we're actually needing to instruct and mentor our students in these days. So as standards keep elevating, some of that sort of content knowledge of the program is certainly helpful.
Yeah, no, that seems to make a lot of sense. We've had a lot of guests come on the show, and especially when we had Terry Pratt come on to talk about, the changes with, whether they should be more fellowship trained, less fellowship trained people on staff. And that's been a big discussion, I know, throughout the PT community. So to kind of get some perspective on, kind of some of the ins and outs and what kind of a day in the life, shall we say, kind of looks as a fellowship program director, what are some of the essential job functions that one has to do as a fellowship program director? And in your opinion, what are the pros and cons of being in this role?
So the roles, I guess, are more varied than I maybe initially thought going into it. Clearly, you're going to have roles of designing curriculum, of teaching, of growing students, but also growing mentors and growing your faculty. So it's leadership, mentoring, counseling, coaching, teaching, organizing, planning, strategizing. It's kind of strategizing. It's like the full gamut. So I think a pro with that is that it's like super exciting every day. There's something new going on. It's never dull. And a real bonus is that with anything like this, when you get in deep with people in something hard that you're working on together, you grow these really good lifelong relationships. So that is a huge pro. I think cons, every job has them. I'd say in patient care, most people would say the paperwork is the drag or the more scut work side of what we do. In fellowship, I would say the same thing. the endless paperwork that goes along with tracking and tracking what each student is doing and making sure you're meeting all requirements. Now, for our programs of requirements of AOMT, IFOMT, and the APTA, so you're answering to 3 different organizations is fairly painful. So that's the con.
Yeah, that's pretty crazy to have to sit there and answer to 3 pretty huge programs like that.
It is.
Well, Julie, what do you think are some of the most interesting or uncommon things that you don't feel that most PTs or fellows are even aware of regarding the fellowship director position?
Yeah, I think some of the one of the positives that I've talked about a little bit is this piece of like mentoring and maybe sometimes also counseling or coaching people. And again, you get in stressful situations, you're in deep, you're in it for a long time. And these, most of the individuals are in these phases of life where maybe they've got young families or nurturing new relationships, or they've got aging parents. Stuff sort of, hits the fan a little bit in life, and they're trying to sort of navigate through this program and gain as much as they can from it. And people hit stress points. And so I think as a director, you're really like blessed to be privy to some of the stuff people are going through. But it's really a kind of a serious responsibility as well to try to help them find the right path for them, even if it's not really continuing your program. So that's something probably most people don't know about. And then the other side would really be how political things can actually get sometimes. I never would have guessed that it would be this way where you really have to be able to team up and work with others in a very political way to try to get stuff done for what you feel is right. But I do think a benefit of that is really in the last years, all the fellowship directors, they're just great people, the ones that I work with in OMPT, and it's been great to work with them in this program director special interest group to try to sort of guide decisions that are made. And so that's been a positive, but it's much more political than I guess I ever would have guessed.
I think it's interesting that you're kind of talking about the humanistic aspect of your role as a director. I mean, as physical therapists, every day we deal with a lot of the same problems in a patient care sense. And I'm really interested in how long it took you to really, develop some of that empathy and really understand maybe what people are going through when they're put in these tough situations and going through fellowship.
I think one is just kind of what your parents beat into your head as you grow up, of the lessons of thinking about others and thinking about their situation and trying to walk in their shoes. So my parents were really big on those lessons growing up. But I think, when you move to the sort of conflict management component of it, I think that has improved over time in being in situations where I've seen people going through rough times or struggling to meet performance standards, understanding what their life is about and trying to really help them, find a winning solution for them. So I think that sort of has developed a lot in me over the last 10 years of just being in the trenches with people.
Yeah, I mean, I think that experience with any type of situation like that is really valuable, especially, even if you compare it to patient care, the more experience one has, typically the easier they can spot patterns and deal with those situations. The other thing I'm really curious about, going through PT school, I did a ton of research as to what program I wanted to go to, what I was specifically looking for in a program. And I was really interested when I would talk to programs about, what made their program better than anybody else's or unique compared to other programs. What do you think makes EIM's fellowship program unique compared to others across the United States?
I think you phrase that well, is really more unique, not necessarily better, because there's a lot of really great fellowship programs in the U.S. And really it's about a student finding the right match for him or her, what's the best fit for their learning style and life situation. But I can describe ours a bit to give you a better picture of what we do. So we're a hybrid model, like a handful of other programs. We have a major focus on evidence-based practice or evidence-informed practice. We take an eclectic approach when it comes to manual therapy techniques, so we don't just sort of teach those under maybe a Kaltenborn approach or a Maitland approach or you name it, different sort of school of thought. Our clinical reasoning model, which is really a major focus for us, is really rooted in the Maitland approach or signs and symptoms approach, but it's really blended with current pain sciences and evidence as well. We believe in looking at sort of the outcomes of what we do. So we've partnered with photo. So our fellows are able to participate in photo and really quarterly take a look at their clinical outcomes, see where they're doing well, where they're not doing well, which can sort of modify who they're focusing on in the clinic with their mentor, can modify where they put their emphasis and where they put the most of their studies and practice to try to shore up those areas. I think we're a little obsessive with this sort of constant update mode. So students can know that their content's being updated as new articles come out and new evidence comes out. We really try to bring it up into the curriculum as quickly as possible. And I guess the other thing is when you look at some programs versus others is we've been lucky to have enough people come through the program to be able to do a survey study, which we did about a year ago. So we have some good proven outcomes that we can show people what to expect when they come out the other end of this process. And it's really, I guess I've been pretty amazed on what our graduates are doing. So, a couple of stats that might be helpful is 70% say there's been a markedly positive impact on confidence in teaching and mentoring. We looked at perception and impact of fellowship on 17 different aspects of clinical practice, and all the scores were 9.9 to 11 on an 11-point Likert scale. Impact on self as a professional was a 10.7 out of 7. Over 75% are involved in research. 30% have done platforms, 30% have done posters. There's 90% are CIs for peers, residents, fellows, DPT students. So, the list goes on. So these grads are really these all-star professionals who have really taken on this idea of not only going after clinical excellence, but really stewarding the profession with really deep involvement in a lot of ways. So I think that is something that maybe is unique in that we've been able to tap our graduates well and then present this data so you can see what you're getting into when you come in.
I would totally agree with that kind of conclusion that you've made, Julie, because I still remember one of my clinical mentors that I had when I was going through PT school. I did a rotation at Stanford University, and one of my clinical instructors there had gone through a residency and 2 fellowships. And he was 10 years out of school, but I was just so amazed at how confident he was in his abilities as a physical therapist, how thoroughly he thought through problems, and even as a teacher, how he just really, really challenged me every single day in the clinic, past, I think, any other clinical instructor I ever had. So I can definitely say that, from personal experience, it seems like when I had a fellow teach me, I definitely benefited a lot from it and really got a lot out of the experience.
Yeah, that's awesome. That's a great anecdote for sure that supports, what I've been talking about.
Absolutely. And I think even, as clinicians, I know this has been brought up earlier in terms of how a very key aspect of the program, even not even just fellowship people, but even people that are just going through regular clinical practice, is that we constantly need to continue to look for ways to improve in terms of how we're being as a clinician, but also as a person overall as well. But I'm kind of curious for maybe our listeners who perhaps are out there who are not sure, how is the EIM fellowship program specifically looking to continue to change to improve the best quality of fellowship training to their fellows?
Well, one sort of recent event and big news is that we have partnered with Bellin College to offer regionally accredited college credits for our coursework. And now in this program, the fellowship is actually the first step towards a doctorate of science in PT. So as many of you have maybe seen, as fellows, as people go through fellowship programs, often they really hone their clinical expertise and get so excited about that, they really want to teach those skills to others. And so they become driven not only in clinical care, but in education. And then they often have a desire also to get involved in research as well. So the areas of interest for graduates really expands. And so this Doctor of Science component will then add this next level of opportunity for fellowship graduates to get more training in the specifics of academics and education and conducting research, and also in the bigger picture of really developing as professionals to really steward the profession. So that's a big deal. And as of this coming Saturday, will actually be officially Bell and College OMPT Fellowship. So you can think of it as kind of being powered by evidence in motion, because the curriculum and the faculty and the program aren't changing, but now we're adding all the benefits that a college offers. So those are adding a vast online library, a network of multidisciplinary colleagues, writing assistants, tuition assistants for some students. So I think all of these are really big benefits for our fellows in training to be able to have these opportunities and then be able to go on to the DSC if they want to.
Yeah, that's awesome news. That's definitely one of the things that we run into over these episodes is just wondering how we're going to get all these terminal degrees to people who, may want to teach in the future, and how these new DPT programs that are coming out left and right are going to be able to staff their programs. So I think that gives a pretty good option for people who are interested in maybe looking into a terminal degree at some point.
Yeah, for sure.
So let's look at the student aspect side of things, Julie. With the burden of DPT student debt and financial constraints added to enter a fellowship program, and now with them requiring to complete a residency or obtain their board certification, what type of person, based on some of their life goals, career paths, should really consider doing a fellowship in this day and age based on a lot of these barriers?
So one is this real there is an assumption on cost and benefit a little bit. And so I do have some cost and benefit sort of data that I can share, at least from our graduates. We conducted that survey I talked about earlier about a year ago, and about 20% of our grads did get gross salary increases in their main job, and the mean average or the average annual salary increase was about $6,000. And then 60% augmented income with teaching or mentoring, and that averaged about $9,000 a year. So the total income change for the graduates, so this is all graduates in the survey were included, was about $9,500. So if you look at it really as return on investment, you could pay for your fellowship tuition in a year and a half upon graduation. So one, as I think, at least for our program, and I would assume that this would also fit for other fellowship programs, is you will get financial payback, especially if you dig into some augmenting ways of augmenting your income. And this is especially true if there's programs that really do some work with their students or fellows in training on teaching them to teach, teaching them to mentor, and growing them in that regard. So in the long term, I think you do cover tuition costs pretty quickly. But kind of back to your note about what type of person should do it, I think, in my opinion, the number one thing that fellowships do is really enhance clinical reasoning skills, really regardless of the subspecialty area. So if a therapist is very much driven to be the best that he or she can be, then I think fellowship training should be on the table. It clearly has to be the right phase in someone's personal life. And clearly, if their professional goals would require it, it's important. So, for example, if you want to teach TE courses, you want to teach into a PT program, having that credential of having fellowship training behind you could help you. And I think there's obviously other skills of developing communication skills and leadership and networking professionally, igniting passion in you as you grow and learn. So there's a ton of benefits. So somebody who's after all this, which I would assume is most therapists, this fellowship training would be a benefit. So you just kind of have to weigh it out on, I think, time of life and how it fits with your goals.
Yeah, I think that that's a really great point, Julie, as far as, really analyzing, does this really fit with you as a physical therapist? Does this really fit with where you see the trajectory of your career? I'm kind of a research nut, and I still remember graduating and reading that 2015 study in JOSPT. I believe you were an author on it. The main author was Rodagero. Well, you guys looked at outcomes with fellowship-trained physical therapists compared to residency, non-residency trained PTs. And the conclusion for our listeners that maybe haven't read this study stated that fellowship training may contribute to statistically greater patient outcomes. Residency training did not appear to contribute to improved patient functional status, change, or efficiency. And it is unknown whether the statistical differences observed would be clinically meaningful for patients. This study, as far as I know, is really the only study or only research that covers the difference between fellowship-trained physical therapists, residency-trained, and non-residency-trained PTs. First of all, if there's another study out there, please let us know. And are there limitations with this studies?
Yeah, I mean, there's definitely, as with every study, right, there's limitations. And this study was really a first pass. The research, as you've identified, is there's not a lot in this area. But, if you look at, say, the number of clinicians in the study, that if you look specifically at residency and fellowship, there were 12 therapists worth of data that were included in fellowship training. We don't know which programs those folks went through. Are all programs really equal in sort of the product at the end and the fellow, that they graduate? Only 45 clinicians had residency training, and there were 306 PTs without residency or fellowship. So, the first thing is these people may or may not represent fellowship or residency trained graduates as a whole. So it's just a sample. It's just a first pass. There are other issues that we brought up in the paper. It's retrospective data from a third-party database. So is that generalizable? Obviously, not all therapists participate in photo, right? So you're already funneling down to therapists who participate in photo, or their employers drive them to participate, but at least they're sort of collecting data. How many are out, not collecting data? We have no idea what, their clinical outcomes are. So we don't know if this sort of sample is really representative of the greater therapists. Only patients who had intake and discharge scores were included. So we don't know what happened to those with incomplete episodes of care. And then you really, I think, just from a philosophical sense, have to step back and think, okay, clearly patient outcomes are important, but what about a lot of other areas? What about the impact on residency or fellowship on the person as a professional, on their motivation, about their leadership skills, on their drive to learn over time and continue improving? What about their ability to sort of get into this community of care with other healthcare providers? How do they work with these other people based on the knowledge base and skills they have? And what about long-term outcomes? So, photo and other short-term outcomes don't look at, say, what happens downstream. Maybe outcomes might be similar between my therapist and your therapist, but what if, you're a higher quality clinician than I am, and your therapist ended up maybe avoiding all kinds of other comorbidities downstream that mine didn't because of the care that you provided. So we don't know about what seeds are planted in that episode that impact patients long-term. So I guess this study was a good first study. It's at least something in an area where there's almost nothing that's been recent, in this last decade. But it's just a first step, and we need a ton more research, educational research, and post-professional education and impact of residencies and fellowships.
I think you brought up a lot by kind of really going through kind of the limitations of this first round of this first study that really looks at this. I think that'll also help pave the way, or at least get some things for consideration to people that are listening, perhaps that are maybe want to do research more into residency, fellowship, or kind of this post-professional path. So I really value that insight there. And like you said, there are many limitations with this study, and broad generalizations cannot be made. As to add on to your points on limitations, is that there were considerations among the therapists in these groups that should be considered, really. So I want to stress this to the listeners, that we must remember to always critically analyze an article, including but not limited to the methods, data collection, variables, limitations, study group, sample size, and many others to understand all the aspects with the study. As what I do not want is for people to simply just read all research conclusions and accept they are true without analyzing everything. Julie, it's interesting because, as we kind of were alluding to before, that there's not a lot of research on this, really. I'm just kind of curious, why do you feel that there is not more evidence on this, frankly?
I think a big area is you got to look at funding. Funding drives research, and we'd like to all believe that it doesn't, but, it takes a lot of resources to pull off research. So I think where the association and where, granting bodies put their money is where research is going to be conducted. So if you look at money out there for educational research, it's pretty low compared to other types of research. Also, it's probably not really as educational research is not as attractive probably to the greater population of therapists, maybe just not quite as sexy overall. If you're going to pick articles for a journal, you may choose one on maybe clinical outcomes over educational research. And really, we're still in the infancy stage for educational research, especially in this particular area, and post-professional research. So when you start out a line of research, often it's going to be maybe at a lower level to begin with, because you really do need things like survey studies to get a basis for what's happening and then build on that. But a lot of journals don't want to take survey studies at this point, or don't want to take levels, because in other areas of research, you get a lot higher level research that's currently being built on other studies over time.
Is the main source of funding for the educational research that you're talking about from the Academy for Physical Therapy Education through the American Physical Therapy Association, or are you aware of other funding sources for educational research?
There's other areas where you can get research, but often it's like $1,000 or $2,000. Those sorts of things help you pull off a survey study. But, you're not going to get $1 million grants or, these high dollar ones to drive educational research. But there's a diverse sources to be able to tap into this. It's just the dollar amounts are not so high. And when you don't drive as much to offer, you're not going to get as much people go in that direction.
So, Julie, I'm curious what your thoughts are on the ABPT-RFE fellowship application standards that will tentatively start in January 2020, with them now requiring the students to complete a residency or obtain their board certification prior to starting fellowship. From your role as a fellowship program director, do you think that's going to be beneficial or a hindrance? How do you think that's going to play out?
Yeah, I guess for the first part of the question on thoughts on the overall sort of standards is I think the APTA did a great job in really investing in this external review process. They have some real positives for programs that are not directly tied to the item that you brought up, but an example is they extended the timeline for part-time fellows in training to finish the program. So for people who are juggling work and families and training and education, this is a really big win. They're limiting the number of sites that have to be visited during the credentialing process, which really comes down to finances. If they had not sort of adopted their standards to the voice of the stakeholders of the programs, it would have really financially shut programs down, because we really work hard to sort of break even, and their change in standards would have shut a lot of folks out. And then, this issue of OCS or residency as requirements come in, I think is a big dilemma. I think it's a problem for a lot of programs. And I guess when you step back a little bit, again, philosophically, and think of the big picture, I think there's some considerations. So the APTA has really gone down this path of kind of trying to look like the medical model. You go through your physician, your initial, medical school, then you go through residency, then you go through fellowship. Well, we don't have federal funding that physicians have and medical programs have. So it's a real problem, obviously, for us, because we add, as you talked about earlier, add more hoops, more requirements, financial debt goes up, and PTs don't have the income at the other end to really absorb that. So on the one side, we're saying we want to grow fellowships and residencies. And then and that all PTs should really go through these residencies. And yet the finances don't work out for people to just pay their basic bills and survive and do something they love to help patients. So I think that's a problem. A potential winning solution that I haven't heard the APTA talking about would be, if we really want our fellowship graduates, if the goal is to know that they own the content knowledge of a specialist, so for example, going into OMPT program, that you really own all the information of an orthopedic certified specialist, and then you've subspecialized, why not just have them need OCS as part of their graduation requirements, and allow that training program to not only get them past that hump of really owning that knowledge, but then also adding that, having that subspecialization. So this sort of shift in the thought of not having it be an entry criterion, but rather sort of one of the many requirements to graduate, would not limit the flow of eager PTs into fellowship. It wouldn't threaten survival of programs, which on the one side we're saying we want to grow, and it would still allow that PT to really demonstrate proficiency in an area while then subspecializing. So I think it's a huge issue. And another big issue that just quick throw in is, I told you before that we, at least on PT side, we fall under IFOMT, AOMT, and the APTA, and yet the standards don't match. And so that's a huge problem that at least, the program directors and the AOMT executive are really working on, but that's a big issue. So the new standards, there's some good, there's some bad, and there's some in between, I think, is probably the best answer.
Yeah, it seems to be definitely a common thread with all these things. And, Julie, I'm going to go back real quick and talk on one aspect of this specifically, because throughout doing the podcast, we've definitely heard people talk on either sides of this issue. And I'm just really curious to hear what your thoughts are. And what I'm going to ask you about is about kind of overall the examination for the OCS. I've heard some people say it was good. I heard some people say it wasn't so good. I am really curious from your perspective on what are your honest thoughts on the exam overall?
Part of my answer is that I can't honestly speak to the recent exam because I took mine. I'm now at the point of needing to recertify the second time. So I haven't seen that exam in 20 years. So I'm not sure is the best answer. Back when I took the exam, I thought it was a decent exam for really book knowledge. I really wished, obviously it would be difficult to do. I wish there was some component of some form of practical exam, but really the pragmatic side is, how would you do that in any form of economically sound sort of fashion? Someone can look pretty good on paper and answering brain questions, but maybe when they actually then interact with the patient don't look so good, So it'd be good to blend those two somehow. I don't have a good answer there.
So obviously, Julie, I know you mentioned before that there are so many influences and things that really kind of help shape fellowship education and curriculum and such from, as you said, AOMT, IFOMT, APTRI, APTA, and of course others. But let's pretend for this situation here that these barriers don't exist. So if you could modify your own fellowship program and the sky is the limit without any influences from any other organizations, what would your ideal fellowship curriculum and program look like?
Yeah, I've pondered that one for a while. I think I'd probably allow a bit more variation in the programs. From a credentialing side, oftentimes there's a real push for consistency. That word is brought up over and over and over, but it's often applied to maybe techniques that a person uses, or everybody is exactly the same in their reasoning process, or maybe communication skills are the same. But I guess I'm not after creating like a factory line process of widgets. Like, I want to be able to have the consistent piece be thinking skills, communication skills, and things that are important like empathy and caring, and the ability to quickly translate current evidence into practice while still tapping an individual's particular passions, loves, and their skills to the best of their ability. So to make the person the best that they can be, but they're not all going to look the same. The core is the same. The important things are the same, but I guess where I would say the consistency is important is maybe not where it's being looked at overall. And so by the credentialing process. So, how would that look? One example may be that we are actually able to have some additional sort of tracks in a program. So someone maybe comes into OMPT, manual therapy fellowship, but they want to translate that into the neuro rehab area. Maybe they take some neuro courses that help them feed it in that direction, or geriatric courses or pelvic health courses. So to allow more variability in that person's subspecialization, as long as you have sort of a core component that is the same or consistent. Maybe more trust to the programs in that sense, that we focus on the consistency that's important, and we get to actually tweak and vary to tap that person's passions and skills.
Yeah, Julie, that's a perfect transition to my next question. But, with, of course, not wanting the pendulum to swing too extreme to either end, of super standardization, but not wanting programs to have a free-for-all either, what do you feel like is the actual Goldilocks zone in regards to standardization among fellowship programs?
Yeah, so that's an excellent question. I guess, frankly, I don't have the perfect answer here. I think the Goldilocks zone is really where accrediting bodies are highly interested in input from programs and other stakeholders, and where they're very responsive to the needs of programs. Standardize enough to make sure that you sort of take out the bottom dwellers, or the people that really aren't doing a good job, but yet not stifle creativity and development to enhance and improve programs. And where that all falls, I'm not sure. I know that we're not there yet. The people involved in the accrediting bodies are very wonderful, sort of thoughtful, well-intentioned people. But I don't know if you've heard of that, the parable about like the road to Abilene. It sometimes feels like we're on the road to Abilene, like we're moving often in this direction of really overstandardization or regulation, or overregulation, like for licensed professionals. But have we really stopped to think about, is this the right road or path to be on? People already have their license, they're already practicing. Do we need these many, many layers of regulation for practicing clinicians? I guess I'm not sold on that. So back to your question, I guess I'm not sure. I'm not sure where the Goldilocks zone is, but we're not there right now. I can tell you that.
Yeah, and that's definitely been a big issue and topic that's been discussed by many educators. I know we've had people talk about specific issues within entry-level education and post-professional, and how those are definitely a little bit of a different dynamic, and things don't work exactly the same. Of course, there's some similarities, but there's some differences. So I agree, it's definitely a big issue, and I think at least there's steps in the right direction to at least find that out. So that's promising. But yeah, I think we still got a lot of research and stuff to work on that one for sure. But Julie, we'd like to end each episode on this one question, and because we love to hear what every single guest has to say about this. Of course, with us being an education podcast, we have to ask, if you could change one aspect of healthcare education, whether that be physical therapy or other healthcare provider related, which aspect would you change, and how would you change it?
I think if I could change, one thing would be, it's hard to go to one, but one thing would be to have more multidisciplinary exposure very early in professional education, and repeated exposure that's formalized in post-professional education. I think getting PTs or students in hospitals alongside primary care physicians and specialty physicians and care providers really lets PTs, see where they fit in the greater healthcare system. It can give a PT much more confidence in his or her own skills, and really bolster that therapist drive to really perform in this direct access format. I think it helps to limit really stone throwing that's often heard from PTs towards our medical colleagues. I think once you really sit in and see a primary care day and you sit through it alongside a provider who's a well-intentioned, hardworking provider, you can see where you really want to be part of the team and make a difference and not, really pass blame. So I think it helps on the teamwork side. I think it helps you see that, we don't have all the answers in healthcare. We have a lot of answers, which are like super high yield, super low risk, but we are still part of a bigger team. And so this exposure and repeated exposure would help us to see our roles a lot more clearly in healthcare and in health promotion. So I think that could be a game changer. I know at least it was for me, seeing that and being part of that in my entry-level program and immediately upon graduating and again in my fellowship program. It was really a game-changing experience for me.
Yeah, and I think that we would have a lot of our former guests as well as our listeners agree with that, Julie. So thank you for bringing that up. If people have more questions for you, talk to you about fellowship, where can they reach out to you?
Primarily email. You could use Julie at eimpt.com. I am on social media some, but it's not my regular place to hang out. So email is really the best place to get me.
And we'll put Julie's email in the show notes for our listeners if they do want to contact you, Julie. Thanks again for joining us, and we'd like to thank our listeners as well for joining us. This has been a great conversation. We've learned a lot about fellowship, and hopefully we've helped people identify whether fellowship would be right for them.
Perfect. Thank you so much for having me on board.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available on our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.